I'm sure now you all are the final years doing the professorial appointment, right? And you all are finishing this batch, right? So I'm recording this so that the people who have missed this class due to overlap with one of the previous lecturer's clinic, so for the benefit of such people who have missed this class because of the overlap with some clinics or other classes, I'm recording this, okay? So forget the video, you're supposed to ask questions and this has to be a bit of an interactive session, okay? Right. Now in 4th year you have done psychiatry 1 month and we have given the lectures from Peradeniya, the history taking, and the MSc. Who gave you the history taking class of the 4th year? Is it me or any other lecturer? You don't remember? Dr. Deva. I did MSc. Okay, great. Right, good. So whoever who do the class, it's the same. Okay, I am trying to teach you how to kind of organize your history so that you guys can present it in, you know, within the given time. Which is the given time? What is the given time? 30 minutes with the patient. Okay, then you come to us 15 minutes with both the examiners. Okay, so roughly about 7.5 minutes to present your findings and then another 7.5 for the discussion, right? So it's a bit of a challenge for us to present your findings in an organized manner within the given relatively short time, right? That's why I was a bit unhappy when people had to take like 45 minutes to 1 hour in the morning to fill a form, you know, take a history. But anyway, it's alright, it's the first day at mental health clinic. So, anybody with any history for the moment? Anybody with a history of a depressed patient? Have you got anything? I would like to have your name tags actually. Where are your name tags? Because, yeah, please take the name tags and have it on you. Subhani, why don't you have some history? Yes, why don't you just give me the introduction of the history? Is the sound okay, Chandra? Yes.
Hansika, an 18-year-old girl from Ukurela who is currently schooling, educated at the advanced level class, singer who has one sibling who is a brother, and parents who are teachers.
මේක අනිත් පැත්තට හරවගන්න. නේද? උඩට මට දැකලා අරකට ගලේවා නම් අපිට ලේසි. Can you manage? That's better. Yeah. Yes. Your patient's name is?
Varuni Hansika,
Uh-huh.
an 18-year-old girl
Uh-huh.
who is from Ukurela. She's
From?
Ukurela, Matale.
Okay. Okay.
Currently schooling and studying in an advanced level class.
Uh-huh.
She's single. She has one sibling, an older brother, and parents who are teachers.
Teachers. Ooh. All right. So that's your introduction. Right. Not bad. We'll try and improve it. Okay. What is the first and foremost? Of course, we have to have the name of the patient, right? It is such a simple thing, Nilama. You may wonder, what is there to talk about? Name me. But I insist, since this is an international examination, Peradeniya MBBS graduates are going to go beyond borders and conquer the world one fine day, and some of you all are going to do very well in Sri Lanka, right? So it's always important to know the correct and English wise and everything, because it's an English medium exam. So it's always good to come up with the correct terminology and the better way in presenting, because introduction is the first thing. When you go and sit and open your mouth as a candidate or as a presenter, and introduction of your patient is the first and foremost thing. First impression is the last impression කියලා සිංහල කියමනක් තියෙන අහලා තියෙනවනේ. Right, cool. So name maker, I need you to use the name in a bit of a sensible manner. Most of us Sri Lankans have very long names with about 2-3 middle names and very lengthy surnames and all that, right? In your short 7.5, if you are going to pronounce the the whole name or the long, lengthy surnames, it's going to, one thing it's tiresome, one thing it is time consuming, one thing it's very not that practical, isn't it? So Varuni Hansika, right? So she's an 18-year-old schoolgirl. So it is, nobody is going to find fault with you for a young child, adolescent, or a very young adult like your patient. You can just say Varuni. Okay? But if you think it is not that respectful, you can say the whole name. She is Miss Varuni Hansika, 18-year-old. But then throughout the history, you can use the word Varuni. Okay? But don't term names like this. Mrs. Tilaka, Mr. Nimal. That happens in Sri Lankan Delhi dramas. Mr. Nam Ratnayaka, or Mr. Nam Silva, the surname. Okay? Mr. Sarat, Mr. Nimal, ඒවා අර බැරි මරගාත ඉංග්‍රීසියෙන් කතා කරන්නේ සිංහල ටෙලි ඩ්‍රාමාස් වල වැඩ. Don't use those terms. Like, don't term the names like that. Are you with me? Tilaka Nam Tilaka, Mr. Nam, Mr. Ratnayaka, Mr. whatever the surname. Got it? KG Apuha, Mr. Apuha, Apuami Esquire, something, right? Principal කෙනෙක් කවුද අපි කියන්නේ hi Nimal. We don't say like that. Listen, there's some concept called social psychiatry where we use the social context and our experience and the maturity, age and everything into account. Okay, if we get a janitor, it doesn't mean that if we get a janitor we are treating him or her disrespectfully, but some better occupation better. No, use the words of use the name sensibly. Full name, Mr. Nang, surname, hari podi එකක් આવොත් ටිකිරි, 8-year-old ටිකිරි. ඒකට master, අහවල් ආරච්චිලාගේ අහවල් කිය ඉන්න ඕනේ නෑ. Do you get me? Yes, cool. Of course, then comes the age. Age, very specific age is important in mental retardation, in autistic, in children, and in neurodevelopmental disorders such as mental retardation, autism, ADHD. Why? Say, people, hands up those who were with me this morning at the MR clinic. Exactly, go. Yes, of course. Yeah, of course, half of the group was there. I know. We managed. Space-wise. So, it makes a huge difference when you say the age of a child with mental retardation, 5 months and 5 years and 11 months, or else is it 5 years and 1 month, so there is a huge difference. Over that extra few months, the child may have developed some skills even, who knows. Do you understand that? So it's important you give the age, particularly in younger people. Yes, please sit. So particularly in younger people, the month as well. So the name, the age, if it is appropriate, only give the months. Don't go and don't go and harass your patient for the last 1 month and 1 day when he's a 25, when he says 25, not relevant. You have to do the relevant thing in relation to your patient. තේරුණා? පොඩි අය, teenagers, පොඩි අය, children, මං කිව්වා MR, autism වගේ අයගේ it's important that you give the month as well. Right? When you have a when you see an RT or a CR with dementia, you don't really have to go and give the etana months may be important. There's a big difference because over 10 months it can deteriorate, but it's very unlikely that you will get a dementia patient as a long case, right? I'm telling this on tape, yeah. But OSCEs, you may get a case scenario with simulated actors as sons or daughters or relatives. Okay, so dementia, how much I get a long case, then we don't have to worry. No, there's nothing like that. You have to know because dementia is very common and it's getting really, really common at the age of the commencement of dementia, development of dementia is coming down because the aging population is increasing. Okay, so you should know it. Sorry. Subhani's introduction is good actually, but lot of unnecessary stuff. Okay, we'll see what there. So name is there, age is there, and then usually we say what the patient is doing, isn't it? She's an advanced level student, and you also went and said she's single. Ouch. I mean, usually in our culture, advanced level students are not married. Are they? Right, cool. So, I think do you guys think these siblings and what the parents are doing is really relevant to the history? No. These are a bit unnecessary information. Okay, good. This is not going away. I wonder what kind of a whiteboard marker is this. This is actually super whiteboard marker. Good. I hope Department of Psychiatry will not have to pay for the whiteboard of the education department. Yeah, the education. Seriously, I'm worried on that. Make a guy.
Madam, make මෙහෙම මාකස් මෙහෙම
මේවා මේ ෂුවර් නැහැ මේ යන පාටක් මොනවා හරි ගාලා යවුවොත් මේක ස්විච් දාන්න because I need the board. හරි anyway යා මේ අපේ වල we'll see. Right, thank you. Now name, age, what the patient is doing, of course the marital status if it is relevant, right? 9-year-old, don't say she's unmarried or something. Marital status kiyaddi there is a way to do it, guys. Right? Say you see a social phobia, a guy with social phobia, a university undergraduate, right? 25 years, and you guys go and say he's unmarried, and we as the final year medicos, we are older than the science faculty patient who's an undergraduate who's coming to it, and we say like big shots, my patient is so and so, he is unmarried. Okay, and unmarried word we usually don't use in psychiatry because it carries a kind of a, you know, some judgmental effect. So the preferred word is single. Always when we talk about patients, we use the positive things. Single, of course, is a very positive thing, isn't it? Yes. Yes, of course. I agree with you guys. Right. So, married, if the patient is not married, say single. Do you understand? Right. Unmarried, then you can say other patient. 45-year-old patient. Registrar was saying he's single, but then she was going to go and give explanations for. Don't know whether this guy was like depressed. No, there are 45-year-olds who are not married and they are okay with it. That's their choice. Okay, so අර tribal mentality එකකින් ඒව බලලා අයියෝ මේ බලන්නකො unmarried තාම වගේ එහෙම කියන්න බෑ. Okay, single is the term. Are you guys with me? You don't have to agree with me, right? This is better way of presenting your introduction. And from where? Subani? Anna Hari. From Ukuwela Matale. Ne? Now, you have a very posh psychiatrist who don't know where Ukuwela is. Of course, Matale, of course, everybody knows. But say, Bakamuna, for example. Okay? Where do you think Bakamuna is? Anybody? Come on. Ane, we go to Lanka with what? There is a Bakamuna in Polonnaruwa. And there's another Bakamuna in Kandy. So when you say my patient is from Bakamuna, it's important that you say in relation to your exam station, which is Peradeniya. Okay? So Polonnaruwa Bakamuna, about 5 hours bus drive away from Peradeniya. Okay? So it's always important. Matale is in the central province. In central province, in Matale district, although the patient says I'm from Ukuwela, it could be so many bus rides, so many hours away from Peradeniya. 3 buses, 2 buses, get up at 3 a.m. So it's important to know where, Chaturanga, where our patient is coming. Upurasada, ne, kohida kiya, right? Ekaki. Hari. Anith එක ළමයි introduction එකට you can't spend lot of time on introduction. Introduction has to be very specific and to the dot. And you should have your own introduction. Ready wage pat 30 seconds max. You have to finish it. Right? So, how can we improve your introduction, Subhani, now?
My patient is following Ahansika, an 18-year-old girl.
18-year-old?
University.
Advanced level student. Very good.
From around 2 hours bus drive.
Which is about 2 hours bus drive away from Peradeniya. That's beautiful. Specific. Now, if you don't think about the introduction and present it, you will be saying like this, yeah? My patient is Nima Ratnayaka. He is 45 years old. He is a teacher. He is married. He has 2 children. And he's from Pottapitiya. And Pottapitiya is from, he's a suburb in Peradeniya. How many sentences, guys? About 6-7 sentences. Yeah? So, you spend about 1 to 1.5 minutes on that. Aparad, waste. So, 30 seconds. My patient is Mr. Nima Ratnayaka, a 45-year-old bank clerk, married with 2 adolescent children or 2 children from Pottapitiya, which is a Peradeniya suburb. Kathawa ivara. Okay? ඔළුව කහ එතෙන්දි synthesize කරන්න විභාගෙට ගිහිල්ලා presentation එකේදී. You have to have practice even from the introduction. This is why the final year appointment is there for you guys for 1 month. Okay? ඊළඟට මොකක්ද? Introduction එක හරි. Then next. Before that, අපි කාගෙන්ද information ගන්න? Informant. Informant is the patient. එක කතන්දරයක් නැහැ සාමාන්‍යයෙන්. ඉතින් informant is the patient. At the long case level, of course, you have only the patient. Okay? ඕනේ නම් education මට්ටම කියන්න පුළුවන්. Level of education කියන්න පුළුවන්. It's alright. Not very, very necessary. Alright? So, informant. ඊට පස්සේ presenting problem. Okay. Give me a presenting problem. You have a presenting problem, Subhan?
It's enable to carry out her daily activities over the last 6 months duration.
That's all. Cool. So, මට එනවා දැවෙන ප්‍රශ්නයක්. I have a burning question. What in the world was she doing for the last 6 months? Why come now? So, what is that? Why come at this point? I'm pretty sure Dr. Deva must have taught you. Why come now? In other words, yes? Reason for referral. Hari? Take a Peradeniya එකක් නෙමෙයි ළමයි. It's there in the book of reference we give to you. What is your book of reference we give in Peradeniya and all over the country for the medical students? Oxford Charter. Yes, short Oxford of in psychiatry. Okay, even for diploma. So presenting problem එකට කලින් we want reason for referral. Very interesting reason for referrals are there. Okay, hold on. Why come now? When has the patient come, Subha?
In coming to diagnosis of a patient with depression for a long period of time has been on treatment, and this time she is unable to carry out her daily activities of living, and she wastes a lot of her time. So we give some structure to her life. They have admitted her to manage her.
Who has said? The psychiatrist from the private sector somewhere. Okay, is it me?
I'm not sure.
It's all right. It's not. It doesn't matter. Right. You know, to give the structure to the daily life, we don't admit patients. Then maybe we have to admit all of us, eh? Yeah? As if our structures are not that great. But I know what you mean. I mean, well, good. So, Bani, it's like this. You know, 6 months of feature, so she can't work. She can't attend to her daily life, right? I'll get a bit of a easy example for you all, so that we can work out the history, okay? Say, my patient is having low mood, okay, for about 2 weeks, right? Lack of energy for about 2 months, alright? Lack of pleasure. Melo santosayak naha hitata. That is for about 3 months. So that's the presenting problem, okay? Hitannago, the person who has been like this for අපි මේක 6 කරමුකෝ තවත් වැඩි තේරුම් ගන්න 6 months විතර මෙහෙම කතන්දර තිබ්බයිද there are so many complaints okay Hashim so තිබ්බ මනුස්සයා ඇයි දැන් එන්නේ දෙයියනේ when you are the shadow doctor and you are about to leave the hospital at 9:55 your patient is coming I know some of you are there ඒක නම් කරුමේ yeah okay but reason for referral what is the reason for referral? What could be the reasons for referral? Reason for referral කියන්නේ ළමයි ඇයි මේ මොහොතේ දැන් ඉන්නේ why come now? What is the reason? You know when people can't take it anymore in the community of course they bring the patient. What are the very very known or significant or dramatic reasons why people bring patients? Barry that. Suicidal ideas, very good. Patient has tried to jump in front of a moving train on the day of the admission or the previous day. Or patient has tried to kill the next door neighbor whom he believes is having a affair with his wife the previous day or the day of the admission. Okay? Very good. And aggression, not only homicidal, but aggression. You know, there are some things in short of homicide. Suicide and homicide, but aggression to people as well as property. Kudu karala, ගෙවල් දොරවල් කුඩු කරලා TV කුඩු කරලා දොරවල් වලට පොරවෙන් කපලා කඩලා they have bring down the house, some have burned down the house. You know, that degree of aggression okay towards people and property ඒවත් මිනිස්සු ඌනියන් කර කර sorry ඌනියන් නෙමෙයි මොනවද බලිත ඔයිල් කර කර දුම් අල්ලලා බලන් ඉන්නේව නෙමෙයි they have to bring to a proper psych help yeah and what else සමහර ඒවා තියෙනවා ළමයි අපේ කල්චර්ස් වල දරන්න බැරි කතා tell a family මට සන්තෝෂයක් නැහැ හිතේ I have no happiness me okay හිත හදාගන්න you know මටත් ඔහොම තමයි take it easy me ඕවා හරියයි you know that's how it is but you stop eating rice for 3 days පත්තටයක් කටේ තිබ්බේ නෑ ඩොක්ටර් කියලා අරගෙන වතුර බොන්නේ නැතුව හිටියොත් දවස් දෙක not taking anything orally fluids no water even of course those things people find it very difficult to tolerate and sit down they bring the patient to you do you understand so very daranda very things that you can't tolerate anymore in the community not eating or drinking aggression suicidality homicidality right anith එක ඔන්න ලෙඩෙක් ඉන්නවා patient is like washing hands like nothing repetitive hand washing patient knows අයියෝ this is such a nuisance. මොන විකාරයක්ද? I know this is nonsensical, but I feel like washing hands, otherwise I don't feel satisfied. හරි? ඔහොම ඉතින් දුක් විඳ ඉන්නවා. මෙන්න બોලේ අපේ Dr. Dias goes on Kandurata service and give a talk on OCD. Then the patient realizes, Macha, මේ මගේ ලෙඩේ. මෙච්චර දවසක් මම මොනවද කරේ? මේක ලෙඩක් නේ. This is a mental condition. Oh my goodness, I must go and seek help. So, newly found knowledge. හරි? ඒව නිසා මිනිස්සු එනවා. අලුතෙන් මේක ඉගෙනගෙන කතන්දර. OCD එකේ ලෙඩක් තියෙනවා. මේ මට තියෙන features ව තමයි තියෙන්නේ. Okay? So they get either they read a newspaper article, magazine, online, listen to our mental health round table, little clips, video clips we put from our college, right? They all are මිනිස්සු මේවා අලුතෙන් ඉගෙනගෙන they come. Okay? So ඒකත් reason for referral. හරි? reason for referral එකටත් ළමයි time එකක් තියෙනවා. හර්ෂ හුඟක් ඔයාගේ colleagues ලට doctors ලට අමතක කරනවා මේකටත් කාල පරාසයක් තියෙනවා කියන එක කියනවා. When did the patient try to jump in front of the train? When did the patient, for how long did the patient not eat? So 3 days on the day of the admission. So in relation to the admission, hari, oyala balana dineta hari, in relation tama, you have to say the time. What I said is, you have to give the timeline in relation to either the admission date or the date you're seeing the patient. Mehema kiyaddi hari lesi. කාල සීමාව ගන්න. මම මේ කිරලා මැනලා මේ දෙනවා. But when you listen to our patients, you have experience. My goodness, it's very difficult to get the timeline of the patient from the patient. So what do? You can't play God. We can't play God. Yes, very good, Subhani. We give a අපි ලියා ගන්න rough timeline එක. You are here. theme parks වලට එහෙම ගියාම කියන්නේ you are here. So you are here, guys. Okay? So එතන ඉඳලා patient reason for referral, make a presenting problem. Hari? So අපි patient ගෙන් අහනවා, so ඔබතුමීට okay සිරියාවති මහත්මිය මොකද ඉතින් මේ පැත්තේ මේ ඉසේ අම්මක් තියෙනවනේ ડોක්ටර් headache එක ඉසේ කැක්කුමක් right හානේ ඇත්තද කොච්චර කල් විතර දැන් ඉතින් සුමාන දෙකක් විතර තියෙනවා right in psychiatry. Don't jump and believe a short presenting problem durations. Okay? So you ask the Siryavati, ඒ කියන්නේ ඔබතුමියට සුමාන දෙකකට කලින් එහෙම බහින අවුලක් නැතුව හොඳින්ම හිටියා. කිසිම අවුලක් නැහැ. ඒක. එහෙමත් නැහැ මේ මෙතනින් ඉස්මුදුලෙන් දැවිල්ලක් වගේ පටන් අරන් මෙහෙම පිට දිගේ මෙහෙම ගිහිල්ලා මහපට ඇඟිල්ලෙන් එළියට යනවා. මේ නලියනවා, ඇස් නටනවා. right? හටට නිකන් අමුතු රහක් දැනෙනවා. ඔය වගේ කතන්දර තිබෙනවා. ඒවත් තිබ්බා නේද? කොයි කාලෙද? අපේ මේ ලොකු පුතා කොළඹ ගිය කාලෙම. කවද්ද ලොකු පුතා කොළඹ ගියේ? බලද්දි උන්දා ගිහිලා තියෙන්නේ about 6 months ago. අපි දැන් පැනපු ගමන් headache for 2 months 2 weeks කියලා ලිව්වනම් we get wrong time dimension. So always go back and ask. Okay? Mostly the patients you see nowadays, they usually come to one of us in the private sector. Okay? Meda private sector. Before that, they have been suffering for say 1 month or 2 months or whatever. Okay? So, balandoni precipitating. Kochchara kalikata, what is the reason for referral to come to the psychiatrist in the private sector? Not here actually, wrong. Forget this. Api pan hoda. Me pan wala ula. Sponsala madam to kiya. So 1 month is they were suffering. Berimatana. Reason for referral, they couldn't take it anymore. 2-3 days. Reason for referral like a marenda vyana gini diagara something. They come to the private sector. Then the consultant treats. Then actually they gets better and they then come for the follow up in the government sector because they find it difficult to afford private sector. So that's how we usually get most of our patients. Right? Of course we get direct admission. So always have a timeline like this. Otherwise you get really messed up, mixed up about the timeline. මොකද මේ පන්තියක මේ ක්ලාස් එකක කියලා දෙනවා වගේ time duration කියන්න බෑ අපේ patients අට. Most So them are like they're mentally down or changed. Okay, so have a timeline and try your best to get the timeline. If you find it difficult to get the timeline, what do you say? I was trying to see when actually she did it, but she is too disturbed to tell me that. That's it. Don't blame the patient, blame the condition. Hey, you know, because of the condition of the patient, of course, it's difficult to get the timeline. If you find it difficult, then do it. But usually at the exam setting, guys, we give good patients and we kind of coach them. I mean, we kind of brief them how to present the cases. Okay? So don't worry. Api hondata scrutinize kalla thamai patients are then, right? We give patients after scrutiny by the MDs. Right. So presenting problem ke katandare then ivarai. What is the next part? What's your name? Huh? Deki. Deki? Okay, Deki. Yes. What's the next part? Yes? Of course. That's the problem. Very smart. Good. So, how do we start the history of presenting complaint?
This patient in the current episode was because she was unable to carry out her daily activities of living, and she was increasingly wasting her time and not doing anything productive during this time. She was spending most of her daytime in bed.
So you go into description. It's always good to have a starting sentence. Ne? We give some context to these people. Yeah? Tell me a good sentence to start. 6 months ago, patient was okay. So, shall we start our HPC saying that? I will concentrate on my hypothetical patient with depression. Okay? Now, you understand, no? For final years, understand low mood, lack of energy, lack of pleasure. This is like, what is the direction this history is going? Depression. එක තේරෙනවනේ දෙයියනේ මේක මේනියා හැම කියලා කවුරුත් හිතාගෙන නැහැ නේ. Right. Okay. So HPC 6 months ago patient was okay. So give me a good old medical student sentence that we can start this. What's your name? Your name and then the sentence. Chamali. Charuni. Yes, Charuni. There you go. Awesome. Anything accurately will kill me. එන්න ගහන්නෝගේ කියමුකෝ වෙල් කියලා කාට බයි we have not been seeing this patient 6 months ago. Okay, so අපිට කියන්න තියෙන්නේ apparently well තමයි. apparently කියන්නේ මොකක්ද? What's the meaning? පේන හැටියට seemingly පේන හැටියට මිනිස්සයා යහතින් හිටියා ඊයෙන් බහින දුකක් නැතුව ලෙඩක් නැතුව. Okay, patient was apparently well 6 months ago. Then what happened? Patient got ඊට පස්සේ ඉතින් ළමයි. The main reason why I opt to give you this, take this class for you is to tell you guys how to organize the HPC actually. Introduction සුළු දෙයක්. We talked about it. Informant, right? ඊට පස්සේ of course reason for referral. ඊට පස්සේ of course presenting problem. Harida. Now presenting problem එක ලියද්දී this chronological either ascending or descending order is important. තේරුණා? කපුට කන්න වගේ, right? අතනින් මෙතනින් මේක ලියන්න එපා. There should be some order, timeline order, ascending or descending. Like 2 months කතාව මෙතනින් කියනවා 6 months එක මෙතෙන්ට ගන්නවා ආයි 2 months කතාව පස්සේ කියනවා එහෙම බෑ. Do you understand when I say ascending or descending order chronologically? Yes, cool. In my case, usually the reason for referral is very short. Nelaman, onge daude kamata penna hari, 3 days kavine hari, 2 weeks in the gene hari, something like that. No, this is the shortest one. ඊට පස්සේ මම ලියන්නේ ඊළඟ short එක, then the next shorter, then the longest one at the end. So there's a beautiful chronological order. Well, you can start it the other way also. You can start 6 months, lack of pleasure, 2 months maker, then 2 weeks. Yeah, got it? Up to you, but make it sound logical and sequential. Right? So presenting problem. So HPC guys, right? Now I'm going to have a bigger erase this and go for the bigger pyramid. වතුර ටිකක් එහෙම organize කරගන්න නැති නේද චන්දන අපිට. මොන්න වතුර ටිකක්.
ගේන්න.
ආශේ කාපෙන් චුට්ටක් බලමුද? මේගොල්ලෝ ඉන්නවා. Just tell them and they will bring me something. You don't have to stay there. Just come back for the class. Thank you. Right. Hurry. So, introduction, reason for informant, reason for referral. Okay? Then presenting problem. Okay? So, HPC, okay? Tell me your HPC, Subhani.
Patient, this is a diagnosed patient with depression for a long period of time since the age of 13. This time presented.
Very good. So, in Subhani's case, or in most of the cases that you guys will get for the long case or in the wards, you don't have brand new patients as such. You get chronically ill, either bipolar disorders or schizophrenias or delusional disorders or chronically ill, OCDs, panic disorders, dementias, even. එතකොට apparently well. කොහොමද apparently well කියන්නේ? 30 years ago my patients were apparently well. ඊට පස්සේ දැන් presenting problem එක duration එක 30 years. නාන්නම වෙනවා. It's going to be tough because it doesn't work that way because then you have to tell everything in the HPC 30 years. It's not how you put it. Okay? What we can do is, like you said beautifully, well done. Api then a little context to this HPC. Before we start with the HPC, apparently well කතාවට කලින් you give a little context. මොකක්ද context එක? My patient is diagnosed to have a mood disorder. අපි බලන් හිටියේ නෑ, we didn't diagnose. We don't know. We don't have even the clinic books. Okay? We take all this information from the patient. So what do we say? Probable mood disorder. ඒක මතිනේ. We all are final year students. හරි? මොන mood disorder එකක්ද? What type of a mood disorder is this? Episodic, long-standing, episodic mood disorder, probably bipolar affective disorder. Okay? Patient was apparently well on medication up until 6 months ago. Under Mekkage katawa wage, you bring the apparently well thing, but before that you give a little context. Hey, what are we gonna say about the schizophrenic, most probably schizophrenic patients? My patient was suffering from a 30-year-old chronic chronic, right? Continuous, hurry, psychotic type disorder, probably schizophrenia. We didn't diagnose. We get this only from the history. So you say probably. Api chronic vachane, we'll keep the chronic thing for the psychotic. This is long-standing tiagamu for the mood. Okay? No hard and fast rule, but the moment you say chronic, apita enne poda psychotic path. Do you get me, guys? Do you get me? Right, cool. Right. So, you just tell about what the patient says, ne? In the HPC. Can I give you what the patient says? Can I give you an example? My hypothetical patient. My patient, Nimal, was apparently well 6 months ago. Luckily, this is a first time patient. Huh? So, then he developed lack of pleasure in the things he usually enjoyed in life. Okay? He did not watch his favorite teledramas, and later on, over the last 6 months, he couldn't even play with his toddler son. He lost interest. Alright? Then you move on to the other presenting problem. Lack of energy. My patient was having lack of energy. He developed lack of energy. He didn't have any energy in his body. He felt as if he didn't have any energy to go to work in the morning and even to engage in day-to-day activities. Okay? Then of course, he also developed sad mood, low mood. He did not feel happy at all. He was always appearing preoccupied, and his wife also asked why he's so sad, something like that. Okay? Somehow, they get carried away with the presenting problem details. My patient did not have any pleasure. He lost all the enjoyment in life. He did not watch Devani Gamana, Devani Inima. He did not also watch Sidhu. He did not watch Nage Kanya, whatever. Aratira Dahajara Telirama, like, you know what I mean? I'm just exaggerating. But people get carried away, right? You don't have time to waste to explain one presenting problem, elaborate it with 1 or 2 sentences, and for heaven's sake, move on to the next one because you have 7.5 minutes. Okay? Fast yanna. My patient couldn't lift cementi kotta bage, gadol bage. Usada very okkoma kiyanna apita wela ne. Do you understand? But some people now, you all are laughing. But at the exam, like, there was this manic patient, and our candidate, let's see, I was in ward 6, elderly gentleman, he would give manic. As I'm the consultant, I got the biggest gem, and he would go on giving gems according to the hierarchy. The SR got the second biggest, and even the candidate got the smallest, but he got a gem. So our guy was so carried away, and he was explaining about how each and every staff category got each and every manic. So you don't have time to waste like that. Do you understand? Right. So you just elaborate how the patient suffers. Don't talk as if you are reading from ICD-10. We know ICD-10. Examiners know ICD-10 features. So don't come and vomit out ICD-10 DS criteria of depression. My patient is having lack of energy. My patient is having low mood. My patient is a blah blah blah. No. Still tailor-made the ICD-10 criteria to your Sumanavati, your Piyadasa. Piyadasa did not feel like going to the paddy field. He could not engage in the chena cultivations because he felt no energy. Put it, tailor-made it to your patient. Don't sound as if you're reading ICD-10. Okay? Fabricate karanda baya. You can't story tell. You have to tell the patient's story. Got it? So, haridi. Patients kiyana katha kiwa. End of the story da. Is it over? Nani? Patients kiyana katha tika vitara ahala liya ganda. We don't want medical students. I can get a clerk. Ani meka pota liya ganda darling me leda kiyen tika liwa itani end of the story. No. You all are future MBBS doctors from Peradiki. I stress, right? So, we expect more. Why? If you stop here, say lack of energy, lack of pleasure, that's it. Okay? So, diagnosis, sir? Diagnosis? Then leda kiyana katha tika kiwa itanin katandara ivara. So, diagnosis. Exactly. Ochcha tama kiyanne. Ai. Echchara nahuwe. We need more. Is it severe? Is it moderate? Is he having psychotic features? Is he having somatic features? Yeah? Yeah? So, kohe devaliya? Same history. Hari? ඊළඟට අපි අහන්න ඕනේ. When the patient says low mood, lack of energy, lack of pleasure, අපි දන්නවා මේකේ theme එක, මේ ලෙඩාගේ theme එක, තේමාව මොකක්ද? Depression, දුක. Then we know from the lecture notes, classes, ICD-10, books, Oxford, or core textbook of your psychiatry, then Angala book, අපි හැම එකෙන්ම දන්නවා පොලේ මේ depression. මේ යන පැත්ත depression. Then we know from the books and our knowledge and the lecture notes and everything මේ තුන විතරක් නෙමෙයි depression එකේ features. There are so many other features. And patients have not read books. They will not come and tell you all the textbook features of depression, but it's up to us doctors to ask. Right? So you ask. ඒ කිව්වේ තවත් වචන වලින් important positives. ලෙඩා කිව්ව තුනට අමතරව, apart from what the patient says, when you ask about poor concentration, poor attention, weak and pessimistic views about the future, hopeless patient, මට ඉඳලා වැඩක් නෑ, why should I live, doctor? You know, hopeless. There's nothing for me to live. තේරෙනවද? ඒව ලෙඩා කියන්නේ අපි අහන්න ඕනේ, කිව්වේ නැති දේවල් අපි අහන්න. And සමහර ඒවා important negatives. However, my patient did not have any ideas to kill or plans or any collection of tablets or something, or he has not contemplated in killing himself. කොයි කාලේ? පහුගිය අතීත කාලෙද? No. This 6 was history of presenting problem. People, history of presenting problem. එතකොට HPC කියන්නේ history of the presenting problem. HPPO whatever. එතකොට important positives and negatives ටික. However, my patient did not hear voices asking to derogatory, telling him derogatory comments such as you go kill himself or etc. Do you understand? I exclude what? Psychotic features. Second person commanding hallucinations to go and kill yourself in depression with psychotic features. I excluded that. But did you guys hear me say, however, my patient does not have a second person order hallucinations? Did I say that? No. Why not? Because you can't use technical terms in the history. දන්න ඉංග්‍රීසියෙන් exclude කරන්නයි තියෙන්නේ technical terms. Right? Okay? Are we good? Yeah, our English is good enough. Hurry. However, my patient does not hear voices of unseen people talking among themselves in derogatory content. Come on. You are going to use these terms at the exam, I promise you. Because you are going to work with us for the next 1 month. Hurry. හැබැයි කට් කරලා බොරු කරොත් මේවා කියවෙන්නේ නැහැ. එතෙන්ට ගිහින් ලෝඩුව කහ. My patient does not have auditory hallucinations. Can I be more about it? You have to work hard. Then only you will know these things. You have to practice what I teach today. That's why amidst everything, I have this class on the second day itself for you guys. Do you understand? Okay? So important positives and negatives. එතනින් කතාව ඉවරද depression එකේ? නෑ. ඇයි? Beautiful. ඇයි ඒ මොනවද ඒ අහන්නේ ඇයි? Why? ඉතින් ඔය මද this is depression no mean. ඉතින් ඔය මද then depression with somatic symptoms, psychosis ඔක්කොම කියලා ඉවරනේ. So enough no mean. What is this? No, it's not enough because plain and simple depression එකක් හරි plain and simple schizophrenia හරි plain and simple alcohol abuse එන්න chances හරි අඩුයි ළමයි because always these conditions the psychopathologies are collectively coming together. In a depressed patient, it's very common to find a panic attack or a obsession or something. Are you seeing me, honey? Can you see me? Yeah. So obsession. Say, if there's an obsession in this depressed patient, in this episode of 6 months HPC, where are you going to put it? You can't put it in the past psychiatry because it's only now. Do you understand? Coming together with the depressed features. So you have to have a place to write it, right? So, now for heaven's sake, why do you think I am having these dotted lines? My goodness, samaharu මේවට මං ඉස්සර නම්බ කරා. Then my colleagues were like criticizing, "Papa, මොනවද උගන්වන්නේ? මෙන්න මේ මිනිස්සු ප්‍රෝමිලකම් එක කිය history present." So I don't want that, right? And this is on tape for heaven's sake, right? So, no. In HPC is one document. one area. Honey, listen to me. HPC is just one thing. I am just giving this psychological hypothetical line so that you have some organization in your heads. Hari? Kela gila romila kang eka deka kila hema kiyanna history එකේ බුදු අම්මෝ. I don't trust this baggage assumption. Right, okay. So this is patient කියන කතා. Patient story. Patient කියන කතන්දර ටික ඉස්සල්ලා. Right? ඊට පස්සේ based on what the patient says. Patient කියන කතාවෙන් අපි යනවා patient නොකියන හැබැයි අපි දන්න පොතේ කතා. Important positives and important negatives, right? ඊට පස්සේ තමයි අපි කිව්ව associated කතා because plain and simple depression, plain and simple schizophrenia එන්නේ. කොහෙන් හරි obsession එකක් හරි panic එකක් හරි කොහෙන් හරි ඒක අඩු ගානේ කැරපොතොෆෝබියා එකක් specific phobia එකක් හරි you get it, okay? Right? එහෙම තිබ්බොත් ළමයි say if your depressed donkeys has obsessions, you're very happy and they said we are like she got the obsession කියලා අපිට ලකුණු තියෙනවා. හැබැයි ඔය associated factors ඇහුවේ නැත්නම් ලෙඩු පැනලා දෙන්නේ නැහැ. Why? අපි කියලා දෙනවා පැනලා දෙන්න එපා කියලා. ඔය කෝඩ් දාගෙන ඉන්න නෝන අපේ වෛද්‍ය ශිෂ්‍යව ඔබතුමාගෙන් ඇහුවොත් මිස පැනලා කියන්න අවශ්‍ය නැහැ කියලා අපි educate කරනවා. Did my Bhutani students understand me? Yeah. Then one of your double senior guys was a smart ass guy. He was kutu fine with his girlfriend. Man go, hey, what are you talking about? No madam, අපි ලෙඩාගෙන් අහනවලු මොනවද අර එපයි කිව්ව જાති. Man go, you go and have a bath and come. අපේ ලෙඩ්ඩු අපිට loyal අපි කියන්නේ තමයි අහන්නේ ඕගොල්ලෝ කියන්නේ මහන්නේ. So, associated factors ළමයි නැත්තම් නැති දේවල් කිය ඉන්න වෙලා නැහැ. Right? මේ වෙනකොට දැන් සෑහෙන කාලයක් ගිහින්. Okay? My patient also had excessive hand washing because he was having this intrusive thought that his hands are dirty. However, my patient did not have any associated excessive thoughts about the cleanliness of the hands or did not have any check-in behavior, repeated check-in behavior, or patient did not have any palpitations episodically. Did I use panic attacks? Did I use obsessions? No. You can't use those things because these are technical terms. No obsessions, no panic attacks here. No. You have to, in your own beautiful little English, you have to tell, my patient does not have any associated these features. Get me? Hari. මොකද ඒවා තිබිලා කිව්වේ නැත්නම් ලකුණු නැහැ. Right? පෙරදෙනේ ඉන්න ඕනේ මිනිහට ටිම්බක්ටු යන්න වෙනවා. වගේ නිකන් පොඩි දේවල් බැරි වෙනවා. Right? Associated. ඉතින් ඉවරද කතා? තව නැහැ. Hey. What? Is there any precipitating problem here? 6 months ago, make a mune ai. Funny thing, when you guys come to the OSCEs, 4th years guys come to the OSCEs, they really harass the patients. Say, මොකුත්ම ප්‍රශ්නයක් තිබ්බේ නැද්ද? ඉතින් ප්‍රශ්නයක් තිබ්බේ නැද්ද? දැන් ලෙඩ මැරෙනකම් කියන නෑ අපේ ආට මේක හරි නෑ 4th year එකේදී. හරි? ඉතින් මේ මොකුත්ම උනේ නෑ. බොස් බෑන්නේ හරි ගෙදර වයිෆ් නෑ. Right? ළමයි, you don't need a stressor to get a mental illness. තේරුණා? But if there is a stressor, yes, it can precipitate. තේරුණා? Breakup of a relationship leads to all these symptoms of my patient. 6 months. ඉතින් ඕක කලින් කියන්නේ. නේ තව ඉතින් කෝ කිව්වේ නෑ මම මේ විද්‍යාත්මකවරුන්ගේ කියනවර වෙච්ච දේ කිව්වේ නෑනේ. ඉතින් ඒ හරි අසාධාරණයක් නේ මැඩින්ට. එහෙම නැත්නම් අම්මා බනිනවා. Mom scolds. So since then the patient is having these features. Okay? Then why can't we say that and start our HPC, guys? You can, but there's a little risk. Okay. මෙන්න මේක. අම්මා බෑන නිසා රූමත් තරුණිය වසපි නසි. Have you read things like that? Have you heard? Where? Who says that? Maubiba? No. Media guys. Yeah, media guys, right? So, ඉතින් අපි එහෙම කිව්වා. Breakups leads to depression, right? I should have like recorder, but that again, I should have at least 20 depressive episodes ahead. Can you get the joke? Guys, stressors per se usually don't lead to, it's not causative, associated, precipitated. It could be a stressor. Even without a stressor, you can have any mental illness developing. With a stressor, you can have mental illnesses precipitated in vulnerable individuals. Common the vulnerability decide when? From the genetics, the way you think, and of course the social. So what's the model? Bio, psycho, social. Third year ke kaude vila kiyala dila giyane? Kaude? Yeah, I know. Mata matakai. Right. I'm sure you guys remember the color of my sari also, but ugak kayata mataka naha monawada kiyanne kiyala. Yeah? Remember. Biopsychosocial note, this is the time to dig it out. If you have lost it forever, get it from Chandana, from the department. Biopsychosocial. That is the model we expect you to work on in management. So, in stressors, biologically vulnerable manussayuge, in a person who's biologically vulnerable, when that person gets a psychological stressor or a social stressor like a breakup, an abuse by a parent, loss of a child, loss of the job, right? Evage social stressors are, of course, that person can precipitate, and the way you think, the psychological aspect. Samaru you know chow mentality. Oka hariyanne naha. Dostara honda ida? No? Ape kaleka. No, you guys have not seen it. Right. Yes, I'm happy. Yes. So, chow. Negative mentality. Oka hariyanne mentality ke manussayata. You know, it's easy for him to not to cope. So, he's more vulnerable to get a mental illness. Some people are there, tsunami akawa. I know. So that guys, those guys, it's easy for them to cope, right? So it is always safer to say stressors in the fourth place. Right? Stressors. What are the stressors, you know? Precipitated stressors. What other stressors? One dekak kiwa. Precipitated stressors and predisposing stressors, genetic. Abi දැන් ජාන ගැන මෙතන කියනවාද? Genetic stressors ගැන කියනවාද? කොහෙද කියන්නේ? Oh yes, beautiful. Family history. Okay, well done. We write about the genetic predisposition in the family history. මේකේ තව මොන stressors ද කියන්න පුළුවන්? Very good. Maintaining stressors. There's our Somavati. She's a 42-year-old mother of two. She's been beaten by her husband from the day of the marriage. He's abusing alcohol and coming home and beating this woman. In this context of maintaining stressor, her child also fell sick. That is the precipitating stressor. Somavati always had these low-grade depressive features. Then with the child's illness, a major depressive episode was precipitated. Do you understand how the stressors were? So, maintaining stressors and precipitating stressors, if there is any, of course, you can write. Natta, what do you say? Mara vedini mokut stresso ekak naha ni kiyanne. You say, I was wondering whether there's any precipitating or maintaining stressor. There aren't any, according to the available list. I couldn't find any stressor කියන්නේ. එතකොට අපිට නිකන් කියන්න ඉතින් එලා අපිට පාර පුළුවන් වෙච්ච කාලෙක එන්නකෝ විභාගෙට ආයි පාර. I couldn't do it. I couldn't develop a rapport. එතකොට අපිට නොආගේ බැරිකම. That's not the nice way to put it. Yeah. It was difficult to build a rapport because of the condition of the patient. Hey, my patient you don't blame the patient. Okay? So what do you say? You're Sampa? You're Sampa. Sampa. What do you say? Because of the condition of the patient, it was difficult to build a rapport. There. Blame it on the condition, not the patient. Don't take it on you too. Why should you? Okay? තේරුණාද? හැබැයි පොඩි දෙයක් හරි කරගන්න පුළුවන් වුණා නම් ලෙඩාගේ හොදකමට හරි take it on to you. I could develop a good rapport with the patient. ඒවා පුරුදු වෙන්න හරිද? විභාගෙට ගිහිල්ලා ඔය එන්නේ නැහැ. මේ මාසේ පුරුදු වෙන දෙයක් තමයි එන්නේ විභාගෙට ගිහිල්ලා හරිද? හා. Okay. I think ඉවරද HPC guys? ඉවරද HPC? Functional level එක darling patient කියන කතාවල මේනවා නේද ගොඩක් වෙලාවට. Patient could not go to job, patient could not attend to day-to-day activities, could not cook. So deterioration of the function is anyway we should cover either patient කියන කතාවල if there is no deterioration function important negative. හරි නේද? හරි. දැන් මේ කතාව HPCs enough කියලා හිතන අයට මම කියනවා දැන් example එක. මෙව අද්දුටයි සත්තයි examples living examples from the clinic. ඔන්න දැන් ඕගොල්ලන් හෙට පොයේ නෙවෙයි නා. හෙට මගේ adult clinic එකට ඇවිල්ලා ඕගොල්ලෝ ලස්සනටම history එක දෙනවා. You give it up to here. Stressors දෙනවා beautifully. Yeah? You don't start the history saying my patient had a relationship breakup 6 months ago. Then she started feeling low, lack of energy, lack of pleasure. එහෙම නෙමෙයි ඔයගොල්ලෝ පටන් ගත්තේ. But you said my patient was apparently well 6 months ago. Then she felt this. Then all these symptoms were precipitated following the breakup of a 6 months relation or 2-year relationship. තේරුණාද? අපි depression එක ගැන මේ කතා කරා. Right? අපි ඒක ඉවර කරලිමුකෝ. I have to come back to that again. You have to remind me. Okay? To come back to that. Right. That in the sense may stress එකයි break up එකයි. Then I remember. Okay? Right. අපි ඉතින් ওই ටික ලස්සනටම කරලා අපි patient මම දෙනවා clinic එකේදී හර්ෂණි. Yo හර්ෂණිනේ. Yes. Fluoxetine 20 milligram. The patient goes to the pharmacy and we are about to finish our clinic 12:30 එක වෙද්දි කොහොම හරි ඉවර කරගන්න. Then the patient හති දාගෙන දාඩිය දාගෙන පෝ වෙලා එනවා. අයියෝ ડોක්ටර් මේ බේතවල ඉස්සෙල්ලා දුන්නේ මේකට හරි ගියේ නෑනේ. Ouch. After 3 hours waiting in the queue. So what was missing in our HPC? Exactly. What medications, any treatments sorted? What medications were given? Whether the patient was compliant? Any side effects? Did the patient got better? Last bit එක තමයි any treatments attempted. HPC මේ episode එකට පරණ කතාව මෙතන නෑ. අපි තාම psychiatric history එක ගැන කතා කරේවත් නෑ. We are still in the HPC. Now finally after 1 hour we finished HPC. හරිද මේක? ලේසිද? අමාරුයි. Is it very confusing? බුදු අම්මෝද? No, it's very easy. You first concentrate on when the patient was apparently well. If you don't work out when the patient was apparently well, you are bound to get mixed up with the timeline. Nah? I'm telling you. But Professor Dilin Rajapaksa මට වීලු කරන අයියෝ medical student apparently well කියලා පටන් ගන්නවා. I want my registrars also starting. If you can do it properly without the apparently well, I don't have problem. But it's always advisable to say it because it's very clear in your head. Apparently well covered. එහෙන් බහිනවල නැතු හොඳින් මිටිය අන්තිමට කොයි කාලේ. That's what you usually ask. Okay? Got me? Signal? Yes. Good. Yeah. You too. Good. Okay. Then what the patient says with little elaboration. 1 or 2 sentences to highlight and expand the presenting problem. Then based on what the patient says, what we know from the book, important positives, negatives, then any associated features, then any stressors, then any treatments. That's it. Simple. You practice it from Thursday itself. Got it? Right. ඊට පස්සේ මොකක්ද? Family history should come like fast. Right? You can't be thinking. Family history. Good. Very good. You were taught in 4th year you took histories, right? Yeah. ඊළඟට ගත්තේ family history නේ? You better, buddy. Right. What do we ask in the family history? Two things, lamai. Two things. මේ වෙනකොට lot of time has elapsed. You don't have time for monster and catayam. Okay? You don't have time for unnecessary details. Allagu gedara ballage nakute pulliye paata. You don't have time for that. Got it? For hinawna dowa thamai avilla kiyanne. Api ithin ane apoi kiyala han innawa. Ha. Mokadada man kale kෑවේ කියලා. Right. Anyway. No, not everybody. I'm just exaggerating. Right. Family history ke dekha yahan thi. First degree relations, mental illnesses and suicide or epilepsy or any relevant thing. Mahamari adala nattang eka kiyanne epa. You don't have time for that, right? Any relevant first degree relations, mental illness in the first degree relation. But the second thing, the family dynamics. People, we need to hear what type of a family your patient is coming from. Okay? Mother dominant family. Father was always peripheral. Father was never there. Or else, father was abusing alcohol and there was a lot of domestic violence going on and these children grew up in fear. පොඩ්ඩක් family dynamics කියලා නතර කරන්න. හරිද? ලොකු අයියා කොළඹ කොටුවේ හෝටල් එක වැඩ කරන අය. හරි? නංගිගේ පුතා අහවලා බැන්දා අහවල් දවසේ ඒවා අදාළ නැහැ. We don't have time for that. තේරුණාද? So, family history. Then, what history? Your name and then the name. Yeah. Chetana. Yes, tell me. No. Personal history. Personal history. පටල ගන්නවා හැමෝම. සයිකාට්‍රි රෙජිස්ට්‍රාර්ස්වත් පටල ගන්නවා. පටල ගන්න නැති වෙන්නේ. The only way not to get it tabularized, get it mixed up. Remember life events. Personal history describe the life events very simply and only the relevance, right? What is the first life event, guys? Yeah, ipadima. So, birth. Very good. Birth and development. Okay? If you have 83-year-old Oski Archie in dementia, don't go and ask for birth and development. Archie amma datat nathi wela duwala munupurala danne. Come on, right? So relevant. Okay? So birth and development. Then life events. Early childhood. Holmang walata baya tibbada. Yeah? Leda neme. Diagnose specific phobia of thunder and lightning නම් ඒක පාසයි කටකස්. තව අපි දෙන්න වෙන. නිකන් චූටි කැලි තියෙනවනේ. You know, not amounting to illnesses honey, right? You know, patient was very shy as a child, right? Early childhood, he was frightened of lightning, thunder, dogs, cockroaches, right? He was always bitingness and like, you know, ඒ වගේ නිකන් පොඩි anxiety kali අපි කියන early neurotic traits of children, right? ඒ කියන්නේ හරි සංවේදී බය ගොළු හරි පොඩි ළමයි. right? Early neurotic traits, now this is a factor on a theory kalla. Okay, this is a fact. People with early neurotic traits can get later depressive and anxiety illnesses. ඕගලන්ගේ history එකේ ඕගලන්ගේ depressed history එකේ ළමයි, if you could get early neurotic traits, early anxiety traits, little බය කැලිය ආනම්මනම් ටික ආව, that's a very good finding. We will give more marks for that because then you are connecting chaturanga, you are connecting this. It's as if you know the connection. ඒ කියන්නේ අපි history එකක් ගන්නෙ diagnose කරගන්න නේ. So early childhood neurotic traits තියෙන මනුස්සයා when they become an adult, they're more prone to get depressions and anxiety disorders. අපි ඒව දැනගෙන නෙමෙයි අපි ගන්න අර කටපාඩම් කරලා අහන්න ඕනේ වහන. But it looks good on you and yet because there is a theory like that. How about that? Yes? Good? Okay. Then early childhood ඊට පස්සේ school. ඊට පස්සේ ඉතින් මනුස්ස average student any major behavioral problems එහෙම නිකන් not up to leader level but he was a good student. He was holding positions. He was the head prefect. Blah blah blah. Okay, podda. Okay, loku katandara keke inna. Then go adult, young adulthood, right? Relationships, sexual relationships, right? ඊට පස්සේ තමයි ඕගොල්ලන්ගේ ලෙඩ කතන්දර ටික. Past psychiatric history, past medical history, past surgical history. අමතක වෙන එක මොකක්ද? Forensic history. Past forensic history. ඉතින් antisocial traits තියෙන young guy එනවා. ඔළුව පල්ලා ඉරේ විලංගුවේ වැටලා දැන් මාස 6ක් විතර. We missed it. Because we are not used to ask the forensic history. That's very damaging for a candidate. Okay? And for MBBS doctors are very damaging. Because he can hammer you the next time if you don't get that information. Got it? Right. So you have to be careful. Risky is a big thing in psychiatry. If you don't assess, it's very risky for the candidate as well. Okay? Relevant. Right? So, personal history, okay? Right? ඊට පස්සේ premorbid personality. Very good. Premorbid personality. Hey boy, what is premorbid personality? What's your name again? How do you spell it? Those are wrong spellings. Check me. Right, it's not written there. Is it? Some other name is there, right?
That's the second name.
Ah, okay. But the name you're telling me is not there.
Yes, there. Small.
Ah, there is one. Ah, check me. Oh, yeah, of course. I don't know why I can't see now at this stage. Check me. What is premorbid personality, Buddha?
You can get a retrospective idea before you became normal or
Mentally ill.
So you can get a retrospective idea.
Very good. What type of person your patient is, right? Imagine a manic patient who's over talkative, pressured, disinhibited, sexually disinhibited and excessively unnecessarily jovial, and actually very sad to see they're making so silly of themselves, like they're making so vulnerable to be laughed at for the untrained eye. We don't laugh at our patients. We laugh with our patients, of course. Yeah, that's one. Yeah, we laugh with, we never laugh at our patients. Even with a manic patient, we can crack a joke and laugh, but then we must make sure we never laugh at our patients. So imagine this manic person. He must have been a principal or a teacher or a bank clerk or a very respected laborer in a university who has done so well, and it's our duty to see what type of a person this guy has been before becoming unwell like this. So there are so many there are so many aspects why this is important. One thing, we treat it, then of course we can see whether our treatment worked. Yeah, whether the patient has gone back to the premorbid level. Okay, so premorbid personality people, there are so many. Yes, Buddha, what's your name? Do you know what's your name? Isuruni. Yes, Isuruni. Do you know the components that we inquire in premorbid, under premorbid status or the personality? Yeah, how his relationships are. Very good. Name and answer. No one. What's your name? Nipuna. Yes, Nipuna.
Occupational problems.
personal history, any occupational problems, like whether he could hold a job, it should come under life events of a person. We are just generally describing what type of a person this is. The prevailing mood. Take the batchmates. You know, api danna. Havalakut appu. Mala penagata gamamma. Ekko puss mood ne. Maru jolly pora. You know what I mean? So the prevailing mood of the person, right? And the relationships, whether this patient was outgoing, hyper, you know, fun-loving, outgoing, many friends, right? Sabakolyak ඇත්තෙම නැහැ. ඒ type. නැත්නම් reserved, nice. Reserved, තමුග වැඩක් බලාගෙන එහෙම ඉන්න type, right? Reserved, socially outgoing, කොහොමද the relationships. And what else? Yes, the goals of the life. There are about 5 different hobbies. Some people are, the only hobby is computer games. They don't mix with others. Some of course go and get in contact sports. So the hobbies also gives us an idea about what type of a person this is, right? So අන්තිමේදී ඔය ගොඩක් පහක් විතර තියෙනවා. Oxford එකේ box එකක් තියෙනවා. I want, that is the homework. Everybody please go home, right? And read the Premorbid personality. And I usually give all the new groups, when they come to do professorial appointment, pretend that you all are patients. Sorry, pretend that you all are patients, yeah? And do a Premorbid personality on each other. Yeah? Yeah? Where the sampad? Just for fun. So that, no, I'm just kidding. But I mean, think of those lines. Okay? And පොතේ තියෙන අලුත්ම chapter, the latest 8th chapter, I guess. Oxford එකේ අන්තිමට තියෙන ultimate goal of the patient before becoming ill. What is your ultimate goal, people? Our registrars have talked among themselves when I teach the students about the ultimate goal, and they have talked among themselves. They said, "Apita එහෙම එකක් නැහැ." In my case, my ultimate goal is do my job properly, and අනිත් වාතයක් නොදී දෙයරේ කියලා සන්තෝෂෙන් ජීවත්. That's my ultimate goal. Not to become a pain. But I have to become a pain for you guys. But that comes with the job description. Come on. Okay? Right, you have to forgive me with that. Yeah, that's it. Serious, Sarah. Madam, meet up that pain එකක් ඉන්න. Just kidding, right? I will never be a pain. You will get only extra, you know, homework and stuff like that. Okay. So, I want you guys to just read into Premorbid personality a little bit. But by the time you come to the Premorbid personality lamai, ගොඩාක් කාලෙ ගිහින්. Time has gone. Okay, you are just there. For heaven's sake, don't go into unnecessary details, right? 3-wheel එකකින් ආවා, බුරියානි එකක් කාලා, අතන hospital ඉස්සරහ වමනේ දාලා ඕන් ආවා. No, but patients will tell you those things. If you know what to ask, if you have a little structure in your head, you can do it. But going into too much of a structure will sometimes hamper the free flow of the patients. But exams are exams. 30 minutes is all you get. But not only you, all the medical students in the country. And any questions? I wanted you to remind me something and I remembered it. Yes. Good. Some disorders are there. They are stress related. PTSD, post-traumatic stress disorder. You have to start your talking, your history, by giving the trauma name. Otherwise, how can you develop trauma? PTSD history. Yeah? If you wait to take your stressor to the 4th level, but when you go on asking, you know this is PTSD, then of course you can bring the stressor up. Nobody is going to shoot you, right? And අපි දන්න එකම ලෙඩේ depression වුණාට තව ලෙඩ જાති තියෙනවනේ ළම. මොනවද? Adjustment disorders. There are adjustment disorders. ඒවා මේ සිල්ලර නිකන් පොඩි හුරතල් කෑලි. Right? Depression is a serious disorder. But although it is a simple thing, adjustment disorder, it will not be simple if we don't support the patient. Okay, maybe counseling, supportive counseling, problem solving, oh I know. Harida? So adjustment disorder kiyanne the patient find it difficult to adjust to a condition. Migration, marriage, new motherhood, coming to university, starting clinicals, passing an exam, right? New life event, some new thing, some stress. ඒකට ස්ට්‍රෙස් එක දාලා කියන්නත් පුළුවන්, but හතරවෙනි තැන තියලා you can bring it up. නේ? So you can say all these things started when the patient got a breakup. Grief, death of a loved ones. Grief comes under adjustment disorder. Okay? ICD-10 එකේ grief එන්නේ adjustment disorder. And say adjustment disorder, it is the patient is grieving. Depressive type, anxiety type, there are 2 types. Okay? Don't worry. Why are the other type? Right? So this is about the history. Right? Anything else? I'm kind of done. MSc. So I have taught you guys, you can't be making any mistakes in front of me. What I have told you. Tell for heaven's sake whom you're talking about. The Manuse, the subject, the cow, the killing the fire. Nay, and you don't say what the patient is not. When I ask what's your name? Chan. When I sorry? Chanak. It's my child with the like teenagers. Come on, look. Chanaka, no, Chanaka. When I ask you to describe your colleague here, what's your name? Priyavadani. I'll never forget her. Yes, because she's my translator. Right, Chanaka. When I ask you to describe your friend, you will not start. Priyavadani is not a male. You don't start like that. Right? So when you guys talk about your patients, you go and tell me, patient is not having this, patient is not having that. Thought content again. Hari, not suicidal, not homicidal, right? But then you have to say what is in her mind. She's worried whether we can treat, whether her condition will be cured, whether she can lead a normal life. What is in the thought content to then okay? And when you start your patient's MSc, you have to be confident, just like the Vetivage 30 seconds introduction in the history. You guys come and MSc, no. 1 month practice. Common practice kara. You just say, my patient is a male of the stated age. Kiwa vayasa peenawada naththam younger than the stated age, or a bit older than mildly older than whatever. It's a male, the female gentleman. අපි දන්නේ නැහැ gentleman මොනවද කියලා. Right? ඒව අදාළ නැහැ. So male or a female, right? A boy of a 18 under 18 boy. එහෙම නැතුව male කිව්වහම වැඩේ ගොඩ. Because over 18 you don't say boy. But in our culture, still some of us are still having the umbilical cord attached to our parents, mums. We think 27 is boy. Nah, 27 is man. Thank you. Okay? So, without getting mixed up and messed up, just say my patient is a male or a female of the stated age. And hygiene and grooming, 2 different things. Hygiene is දත්ත කට මැදලා පස ඕදලා මනුස්සෙක් වගේ ඉන්නවද පිරිසුදුව. Grooming is ඔළුව පීරන ජෙල් ටිකක් ගාලා ලිප්ස්ටික් ටිකක් ගානවා නම් ගාලා පවුඩර් ටිකක් ගාලා. That is grooming, how you look after yourself. Like don't say well dressed and well built, appropriately dressed and averagely built. Well built නම් අපේ වණ්ඩුක වගේ well built මාති patient වෙනවා මෙහෙම චුට්ටක්. You know what I mean? So don't use those words in MSc. Be sensible and use the words In psychiatry, every word has a meaning. හරිද? Normal කියන්නේ normal. Okay? Change in behavior is a better term, not the abnormal behavior. Because what is abnormal to you may be perfectly normal to another person. And what is abnormal in one setting may be perfectly normal in another setting. Crying at a wedding could be normal, the abnormal.
Normal.
Yes, man. Yes. සතුටු කඳුළු මේ මේකෙන් ගැලවුණා. මහින්සකයා. Yeah. That's all I have to say. Any questions? Yes, Lama. Yes, Tatu. Good.
Three questions, ma'am.
Sure.
One is there a methodical way to find associated conditions, especially when we take history in surgery or medicine, we do systemic review.
I know.
Is there a methodical?
අරක තියනවාද අරක නෑ මේක නෑ මේක නෑ
Or we should thoroughly think about any striking conditions because we have sometimes. Yes.
But you know what? You have to have your own language. You have to look into the associated conditions in depression, schizophrenia. If there are little obsessions or panic attacks, the sanasima, the consolation in psychiatrists, you don't have many. You have few obsessions, panic attacks, and alcohol history. Associated conditions could be social phobia, social anxiety. Teruna. Theory. You should know the theory. Depression එක hand in hand යන්නේ anxiety කතා usually. Okay? So you should ask the anxiety disorders in depressed type histories, right? In schizophrenia, the associated conditions are substance abuse, cannabis, you know, KGO, whatever, even heroin. Yeah. So associated kata අපි theory එකෙන් දන්න skits මනුස්සයෙකුගේ අල්ලලා යන්නේම obsessions everything. When you know that theory, you know what associated factors to ask. අර චූටි පන්තිවල එකේ පන්තියේ කරා වගේ, you know, CVS normal මතකද? පුදු අම්මෝ third year නේ we took histories මෙලෝ අවබෝධයක් නෑ, you just take CVS pulse rate normal, dual rhythm, normal mistake. No, we don't have time for that. So based on the theory, you should know at the end of this appointment, you should remind yourselves, depression එකේ hand in hand යන්නේ anxiety. Alcohol දුකට බොනවා අපේ මිනිස්සු. ලෝකෙ මිනිස්සු දුකට බොනවා. They can get alcohol problems. So associated ඒවය වෙන්න පුළුවන්. Substance use history එක එන්නේ substance history එක එන්නේ past medical past substance උත් past medical එකේ එන්නේ නැත්නම් past substance use history වෙනමත් ගන්න පුළුවන්. Do you understand? Second question. Good question. Very good question. Yes.
And regarding this patient, this hypothetical patient,
Yeah, of course.
it is relevant. Is there family history of suicidal attempt or
Yeah.
suicidal death?
Yeah.
So can we get directly into the history of the person, or do we?
Family history?
Yes.
No, darling. No. Family history should stay in the family history. You don't bring out. It's directly relevant. But you now, Puta, I'm glad you asked. Now, presenting this is patient's history. Patients presenting complaint. Patients presenting complaints history. Family history ka වැදගත් තමයි, because the genetic loading and everything. But family history is staying in the family history. However, there's a however. I hate that word as a student. මොකද ඔක්කොම මොනාරි ඔළුවට දාගත්තා මොන however කියලා. වණ කරලා දාන්නේ අමාරු කළා දාන්න. However, say your patient is worried about a cancer. Okay? Cancer phobia. Mother died of a cancer. Yeah? In that scenario, of course you can bring the mother's illness of cancer or committing suicide for that matter. Patient is worried that she will also commit suicide just like the mom now. You can bring in that relevant part of the family history to your HPC. හැබැයි එතනත් හොගාලා කියනවා family history හොගාලා කියනවා, you don't have time for that. You have to make up your mind. Just a little bit patient is worried that she will also commit suicide just like the mom, and then go to the family and describe a little bit about the mom. Don't go to town with the mother's illness because you have not seen it. What you know is just what the patient says. That's it. Do you understand? Have I answered you? Third question. Yeah. Yeah.
Normally in medical history, we discuss the etiology of the disorder. So if we
We don't. The thing is here, it's like this. Good. Psychiatry history. I don't know, some of your group members were given a wrong copy. Harida? Wrong class. Because some of your seniors came and talked about differential diagnosis and risk assessment in the HPC. You don't talk about those things in the HPC. Evaratha karande. Eva enne management එකේ. Hari? Here, of course, you get information about the risk. Say important negative. Now important positive එකක් කරන patient කිව්වේ මේ ටික විතරයි. But the patient, on inquiry, we find the patient has attempted suicide. Do you understand? Different. There is a difference from the medical and pediatric and other histories in psychiatry. In psychiatry, the course is biopsychosocial. In medicine, Staphylococcus aureus gives rise to and leptospirosis or කුඹුරක වැඩ කරා නම් කොහේ අනුරාධපුරේ කුඹුරු වැඩ කරන පැත්තක කුරු නැගලා then that history is important to get the etiological leptospirosis. Yeah. Here, biopsychosocial, right? So, what the patient says, the symptoms and signs only we use in psychiatry to diagnose the case. Depression diagnosed karana, we don't have biomarkers, we don't have investigations. We go by the symptoms and signs. Do you understand? Of course, there are MRI changes in the brain, chemicals, blah blah, but not in day-to-day life of clinical practice. Okay? So, etiology ගන්න කියලා අපිට එහෙම කරන්න දේවල් නෑ. අපි etiology ගන්න එකට වඩා අපි biopsychosocial aspect එකෙන් ගියාම තමයි අපිට etiology එන්නේ. You know, we get the etiology of our illnesses by biological family history, genetic influence, alright? And then psychological, the way the patient thinks, the psychological erroneous cognitions, wrong thoughts. මටමයි වෙන්නේ මට කවදාවත් හරියන්නේ cognitive behavior therapy වල we attack those wrong thoughts, right? So those things chaturanga are anyway embedded in this history. And social level තමයි stressors. Biopsychosocial is our etiology model. හරි? එතකොට මේකේ කොහෙවත් අර leptospirosis වලට කුඹුරේ හැවද වගේ දේවල් අහන්න අපිට වෙන්නේ නැහැ. Do you understand? Have I answered? Third question.
you get answer.
What's the third question?
There should be mention the substance use and
Yes, Buddha, very good. ඇත්තට මට එක චුට්ට අමතකුණා. Good that you reminded it. Of course, I gave the answer, but substance abuse history also comes in the personal history. Past psychiatric history එකේම substance abuse එක වෙනමම ලියන්න නැත්නම් ඔක අමතක වෙනවා. ලෙඩ ටික විතරක් අහනවා අපිට අමතක කරන සමහරට substance abuse is also a mental health disorder. Mental and behavioral disorders due to substances. ඒක නෝටිකමක් නෙමෙයි මිනිස්සු බොන්නේ. හැබැයි වෙන එක it's not naughty or bad, but they are chemically affected. Okay? Good. Any other questions, people?
it's not abusing them, but just on consuming. So
Yeah, very good. අපි දන්න එකම ලෙඩේ alcohol dependence syndrome විතරනේ. තව තියෙනවනේ. ICD-10 එකේ මොනවද තියෙන්නේ? What do we have in ICD-10, people? What's your name, hon? Sumaya. Yes, Sumaya. Harmful use. Acute intoxication. Acute intoxication. Yeah. Harmful use. Withdrawal. Dependence. And psychotic substance use. Substance induced psychotic disorders. So, social drinkers, right? Social drinkers are there. Harmful users are there. Okay? Not only. So, the word abuse you use when he is meeting one of the conditions in the book. If not, social drink. If not, teetotal. No drinks at all. Get me? Okay. Acute intoxication. කොබලා නතවසන්න හිටපු කට්ටිය acute intoxication experience කරපු කට්ටිය. අර එක දෙක වගේ පේන. යා? පාට එකද? Somehow not all. It's not a good state. Yes. Okay, good questions. I mean, if any question is good. හිතන්න එපා. දැන් මං එකක් ඇහුවොත් මම මොඩේ වෙයිද දන්නේ. එහෙම නැහැ. Yes, are you okay? Any questions? You got everything clear? එහෙනම් අපි yes.
How do you present past psychiatric if it is not relevant?
Very good. Very good. ඒක අපි කොහොමද? Past psychiatric history. Say your patient has 30 years of bipolar affective disorder. Right? Patient has about like 10 depressive episodes and like 6 manic episodes, something like that. Then are you going to explain each and every episode? Now, you have to summarize it and give it. My patient has about 4 features, episodes which are suggestive of mania with over talkativeness, increased energy, disinhibited behavior. Okay? And patient also has had probable depressive episodes with features such as the similar today's episodes, this time's episode, something like that. In your English, you just summarize. ඉතින් ලේඩාට කියා ගන්න බැරි වුණා. What do you say? Patient can't give you the information. Patient has had how many manics, so how many depressives. You say that to us. I wanted to check how many, whether he has had any manic episodes in the past. Why? This patient, this episode is depression, all right. But if the patient has had a manic episode in the past, then this illness becomes what? Bipolar affective disorder. එහෙම නැතුව depressive episodes තිබ්බනම්, if the patient was having only depressive episodes, then recurrent depressive disorder. How do you give the diagnosis? What's your name, hon? Vidurangan. So how do you give a full diagnosis? Now that we have covered the whole history, so you can say my patient has had 2 depressive episodes in the past. Now this is the third one. So give me your full diagnosis. Okay, what is this episode? Very good. Can you qualify it a bit more now? My patient doesn't have any psychotic features or no somatic features. So what's the degree of depression? You have to give me the degree of depression, sir. Mild, moderate, severe. මේ depression එක මොකක් වගේද හිතෙන්නේ? අපේ hypothetical patients depression. නිකන් mild වගේද? Anybody? Are you okay? Shall we try? මගේ හිතේ සන්තෝෂෙට ළමයි දැන් මේ පැය දෙකක් තිස්සේ කතා කරනවානේ මෙතන හිටගෙන. Yes? Very good. Recurrent depressive disorder. Current episode is depression. Current episode එක මොකක්ද? Depression එක. Very good. Degree එක පුතා? Mild, moderate, severe. මේ කියපු කතාන්දර. Severe now, you have psychotic features, severe degree of functional impairment, can't go to work, extreme degree of suicidality. Psychomotor retardation is also taken as a severe psychotic symptom of depression. It's an MCQ actually. So this one, ලොකු අවුලක් හැබැයි අවුලක් තියෙනවා. Moderate. Mild depressions usually don't come to present to us. Mild depressions, you talk to a batchmate, right? And you just go to a religious whatever place and you just make up your mind. You talk to a friend, you make up your mind. Depressions who are more than mild only come to usually the doctors, particularly the psychiatrists. Mild depressions, corridors, they don't usually come to the doctors. Right. So this is recurrent depressive disorder, current episode, moderate depressive disorder. That's how you have to tell the diagnosis. Depression kela api ඊට පස්සේ. So can you please elaborate? ඕවා කියනකන් ඉන්න එපා. පට ගාලා කියන්න. තේරෙනවද? Bipolar affective disorder, current episode, mania, with or without psychotic. Tell. Okay. Any questions? Are we good? Can I tell you a joke about medical students taking histories? Yeah? When we were in the roads, the 11 months, when we were in the roads, we had to go and do some examiner jobs in other universities of the country, because some of them they really wanted to do the exams, and we also did some of the exams, you remember, right? Some of for your seniors. So I have gone to Jaffna, Betty and Ragama and one like Colombo and Rajarata are the only universities that I couldn't go so far as an exam. So when we go, medical students, they present histories, okay? Feel very sorry for some of them because it's very obvious they have got the subject from the book only and not enough staff, and our staff also, you know, like our Dr. Shavindra has gone and done a lot of service, but then, you know, how much can you do when you are far away, right? But nevertheless, there was one common feature, right? Even our guys, right? So they are like telling all these Valvatara, VV histories, Valvatarang histories, and so we want to now stop you guys, get to the track, and we say, come on, Buddha, you have only a limited time. Can you please stick to the most important salient features? Oh, sure, madam. My patient does not have blast allergy. I heard that from Pera, some of our guys, I don't know. And then Rajarata, not Rajarata, all the other faculties in Batty and Komala, they say, no blast allergy. Me, antima tappare then me. Api kiyana ikman karaha. Okay, madam, sure. My patient does not have blast allergy. Right? So ඒ දවස්වල මම ගිනි රාමෙට poster හදන කාලේ, anti-psychiatric posters. Okay? So I really wanted to come home and make a poster like this. රටේ ඉන්න සියලුම විශ්වවිද්‍යාල වෛද්‍ය ශිෂ්‍යුන්ට blast allergy උගන්වපු එක වුණොත් අම්මපා කොටනවා සෙනිකම. Thank you.